Good afternoon, everyone. Happy to see you here. Hello. Good to see people waving. That's very exciting. Goodness gracious. I'm a little out of breath. I just ran from another session, so I'm well. I'm healthy. Don't worry about it, but it's all good. I really appreciate all of you coming here today. My name is Andra Blomkalns. I'm currently at Stanford at a place where wellness is really part of the culture, and we spend a lot of time and, quite frankly, a lot of money on the concept of wellness. And my goal here today is to talk to you, give you a framework by which we can talk about wellness, talk a little bit about the data that we currently know about wellness, and then focus a lot on what I would consider academic emergency medicine wellness and what we can do moving forward. And then hopefully a call to action, because I feel like there's a lot that we need to do on this topic and a lot of places we need to go, and we have a great number of esteemed people who are working very, very hard on this topic, and all of us need your help. I have no relevant disclosures regarding this topic. So first of all, a word on nomenclature. So I've always kind of disparaged the presentations that start with a definition. I'm like, I know what they're talking about. That's why I came. I chose this topic. But for wellness, it's so important, because if we think about it, we're mixing things up. And I think if we don't use the words and we don't know what we're talking about, that it actually becomes confusing. If you can imagine, for those of you who can remember when myocardial infarction became acute coronary syndrome. That was one condition that changed to another set of words. People didn't know what we were talking about anymore. Was it positive troponin, not positive troponin, EKG changes, not EKG changes? Then they changed it to NSTEMI and STEMI, and nomenclature confused people. And I think we can also see that with SIRS and sepsis and severe sepsis. It's sort of like severe death. It's like, why are we doing this? But so I bring that to people's attention because I feel like until we're using a common vernacular regarding what wellness is or what burnout is, that we're going to struggle. And there are several words now. So in terms of wellness there's a personal component, so personal fulfillment. There's a sense of self-worth, and also self-efficacy in terms of whether or not you feel as though you're being effective at work or actually getting something done. And overall, this is a definition specifically about work, but then also a lot of the research talks about work and then personal life, and there's an inherent conflict in there as well. So burnout, I think, is a little easier for us to understand, which I felt, because we know burnout when you see it, right? You know what it looks like in general, but maybe it's more difficult to define in words. However, so we talk about emotional exhaustion. Exhaustion's physical, emotional's emotional, so we're mixing things there. Disengagement and low sense of accomplishment. And I think that's particularly germane for emergency medicine, is this sense of accomplishment or being able to do what we set out to do. So let's make things even more complicated. And now there's this new term that many of you will know is called moral injury. So moral injury is the new vernacular for the word burnout. And it comes from military nomenclature, where soldiers witnessed death or they witnessed injuries. They couldn't do anything about it, and it really affected them emotionally and physically. And it was considered an injury, much less like a physical injury may have been in battle or otherwise. And so moral injury is now the term that's used for burnout, not meaning that we are actively necessarily burned out because we see people dying, but that we are ineffective in being able to do what we need to do when we know what the right thing is. And so it occurs to me as I think about it that moral injury, while I think it's kind of, this is an opinion more than anything, is interesting to discuss in terms of military literature, and I think it gets people to notice it. I don't understand it very well. I have to explain it to myself every time to try to get it through to people. So myself, I'm going to still use the word burnout. So measuring. Okay, so we're scientists in the room. We're interested in science. We're interested in research. We're interested in education. how do we measure wellness? How do we measure burnout? And we don't have really a perfect measure for it. We have several scales, most of which are survey-based. There's the Maslow Burnout Inventory, the MBI. There's the Z, there's the Mini-Z, there's the Stanford Survey, and there are many others. But we can't necessarily, as a society or as a field, come to an agreement as to what is the ideal measurement factor. And if we I think if we're going to consider burnout a disease that we need to treat, or wellness as an outcome we'd like to reach, it's difficult not to have a good measure, and that's unsettling for most of us. And some folks are doing some very interesting research. For instance, and I'm just calling out a couple, Bernard Chang is doing cardiovascular implications of burnout, like genuinely watching people over time, kind of like the Timmy registry of how people who are burned out necessarily, thank you for joining us. Okay, and he's looking at cardiovascular outcomes long term as people move forward over the course of their careers. And we won't see the answers to that for probably a couple decades, but there is something else that's being measured. Other people are measuring salivary cortisol. Other folks are measuring the economic impact. And I think what's gaining increased traction lately is the notion of associating this with physician errors or errors in medicine, and then also patient outcomes. Because until we started linking those things with either money or patient outcomes, the public didn't seem particularly interested. And the public, or who pays taxes, and taxes fund a lot of grants, not exclusively, but we have to get the public interested in this very important topic. So you're not meant to read this, so I won't apologize for it necessarily, but this is from one of the Sentinel articles in Archives of Internal Medicine from Tate Shanafelt that showed different specialties and their level of burnout, or their rank in burnout according to other specialties. So I'll zoom in, and it should come as no surprise, and it doesn't come as any surprise in anybody in this room, is that emergency medicine ranks among the highest. In this specific one, it was the highest. It's not always the highest, but it's usually in the top 3, depending on which one you're looking at. And so you might guess, not looking at this one, but perhaps in the more contemporary surveys, what other specialties are at the top of that list? You can see the ones there, but perhaps other specialties. PM&R, yeah, okay. Anesthesia. Anybody else? Interaction, let's do it. I didn't hear it. Family medicine. And how about the specialties who are the least? Interesting, derm's not. Derm's actually up there most of the time, which I'll allow you to contemplate for a moment. We'd think derm, right? But I think that's a fundamental reason we're misattributing what causes burnout or what is part of wellness, because we say, okay, having a predictable clinic where you look at the same things every day and you know what to do and you get paid a lot of money. No, that's not the secret to happiness necessarily. They're actually at the higher too. But surprisingly to me, neurosurgeons and cardiovascular surgeons tend to be lower on the list in terms of burnout, or higher on wellness. And I'll wager a hypothesis, unproven hypothesis, but I'd like to test it with the collaboration of all of you, is that I feel like in emergency medicine we do a wonderful, wonderful job recruiting. We're mad recruiters. We can sing the praises of emergency medicine, and there are so many wonderful things about emergency medicine. But do we tell our medical students the truth and tell them the other side? I think we're great recruiters, and we're passionate about our field, and we should be. I also feel as though we have a moral obligation to give a balanced appraisal of emergency medicine when we're looking at the future of emergency medicine. And I feel like cardiovascular surgery and neurosurgery, they know what they're getting themselves into. And so it's not a surprise to them, whereas perhaps for some of our specialty, initially we could have attributed burnout to people who weren't trained in it. And I could see you'd be burned out if you weren't trained in your field too, But now we have a whole cadre of people who are residency trained and are not necessarily experiencing the wellness we might otherwise have anticipated. It occurs to me as I talk to my cardiovascular surgery colleagues or my fellow chair, that imagine this, you go to work, the patient is perfectly prepped, you have a team of people around you who have all the materials you need, and you get to do the important part of the surgery in this case, and then everybody else takes care of the boring stuff and the post-op stuff and the follow-up, and then you get to leave and get to go do the exciting thing again in some other room. I'd be well too, right? I mean, I think there are certain challenges of our specialty, and for derm, and for neurology, and for internal medicine, and family practice, that make our clinical practice environment a huge part of this. So we've attracted national attention. So the National Academy of Medicine, previously the Institute of Medicine, approximately 12 years ago published To Err is Human, and now they have published To Care is Human, and talking about confronting the issue of clinician burnout crisis. And I use the word clinician because I'd like to focus from clinician and then move to what we are sitting here today. The good news is that they're attracting national attention on this, and they're attracting the public's attention. And the public's attention is very important in terms of us being able to get some of the research or some of the initiatives funded. Money, even in California, doesn't grow on trees, but nonetheless, it is very important to be able to do things. And healthcare and healthcare economics is not particularly viewed very favorably. So anything we do in this field is going to have to be funded in some way. They came up with this as a framework. I personally find this has too many pieces and stresses me out and burns me out, so I moved over to something else. This is the Stanford one, not saying it's the best one. It's just simpler for me to understand that there is a cultural component, and I'd like to sort of put this forth for all of you sitting in this room in terms of how important the culture of both wellness and recognition of burnout, but the culture within this society, how important it is, the practice environment, which we already talked about, and then the personal component and the individual and how that individual manifests stress and otherwise. So focusing now, we've got the public looking at clinical medicine, we have emergency medicine, but what about academic medicine? It's a whole nother series of stressors. So much of society is looking at the clinical environment, but what about the academic environment? And for those of you who can't see, it says most scientists regarded the new streamlined peer review process as quite an improvement when they're going through a gauntlet of a guy with a bat and mace and a hatchet and a Grim Reaper and a sword and everything else. Being in academics is difficult. Not only do you have to practice medicine, often not in perfect situations, but also then have to put your work out there to be potentially criticized and otherwise, and potentially suffer multiple failures along the way. Good grief, how are we even supposed to get to the end of this? So they have some studies looking at academic medicine. This is all of academic medicine, not emergency medicine specifically. But if you notice, it's the clinical providers who provide, or clinical departments who provide patient care who have the highest, and I'm sorry, red, orange, and yellow are the bad burnout symptoms. And the lowest are clinical departments who don't provide patient care. And you'd be like, I wonder who that is. But there are professionals, MDs and PhDs that work in clinical departments that don't necessarily provide direct patient care, and they do other things. So we see a denominator here, specifically that the patient care part of academics is highlighted as a significant part of what people have burnout features. But burnout is not just associated with clinical academics, it's also associated with basic science academics, and overall all faculty manifest some symptoms of burnout. So I mentioned one way to get people's attention is how much does burnout cost, right? Does it cost things in time or does it cost things in money? And Stanford's come to the calculation that burnout, physician burnout, clinical burnout, manifests itself as at least $7.75 million a year. And that's both in lost physicians, recruiting new physicians, patient errors, litigation losses, and otherwise it's all encompassing. And I say that not that this is an extraordinarily large number, I think it's actually a much bigger number, but that using an outcome of its effect on finances is a measure that I think may be worthwhile. We think about emergency medicine has wonderfully embraced investigating burnout and the concept of wellness in our most vulnerable, I think, population, which are our residents. And multiple studies have done multiple things that aren't surprising to, say, emergency medicine residents because of the variability that they need to do across the hospital, the shift load or overload or circadian rhythm balances, and also the very same things that we talked about before, moral injury or burnout or otherwise, how much it affects them. So I applaud our specialty and I applaud academics in our specialty for looking towards this and measuring that our residents are burned out. I don't think it comes necessarily as a surprise, but nonetheless an important thing to note. So we're teaching our residents now about burnout, and I think, or wellness, and I think that that's important, and perhaps we should reframe the discussion in terms of what we want to achieve, which is wellness and perhaps not burnout. We're a very disease and negative associated specialty, right? We look for bad things. We look for disease. We approach people with what might kill you today, and that's wonderful, but I think it's kind of setting us up for failure in some ways that I think we should reframe the discussion in terms of the pursuit of wellness and the pursuit of resilience, rather than necessarily focusing on all the things that make us burned out. But once again, our specialty is doing a wonderful job of identifying our vulnerable population, trying to teach our population about it, not necessarily with I think not enough emphasis on perhaps our more senior faculty, because our senior faculty get burned out as well. Tate Shanafel, who's currently at Stanford and is a wonderful advocate for wellness, is sort of like, okay, we know they're burned out, now what? And that's a huge question. We don't necessarily have the answer for that, but we're starting to look at it, and I'm hoping that people in this room, through their nodding and otherwise, are recognizing that we have to sort of, now what? It's the classic thing in science, like I found this thing, but so what? So what and now what, I think, are critical for these. This is a study talking about restoring faculty vitality in academic medicine, and I mention it because I think a lot of times we attribute that these efforts have to be costly or need large benefactors or large donors. And this was a very small but interesting study where they took faculty members and they just forced them, they actually paid them, but nonetheless, to spend time together. One group would spend time together talking about their day and their challenges and what they might want to do about them or how hard it is. And the other group was told just to talk. And they could talk about whatever they wanted. And I think the impetus was they gave folks food. That was the thing. And they noticed that after 6 months that people who had the opportunity just to speak about their experience with other colleagues were doing significantly better than the other group. And that effect actually persisted for a year after the intervention stopped. So I don't think wellness initiatives have to be expensive. I think that things such as gratitude and personal interaction and justification and realizing what's going on, which I think are pretty cheap, or the price of some boxed lunches, is very effective, and perhaps one of the few things that I've seen that's actually been effective over a long term after the intervention. So in regard to academic medicine, we have several societies starting to pay significant attention. So it's not simply the National Academy of Medicine, which is everyone, but the AAMC has also developed a statement which states that it supports a culture specifically in academic medicine for the well-being of faculty, staff, and learners. And I think this is important because the hospitals have to listen to the AAMC. They have to listen to the ACGME. They have to listen to the RRC. There's all these things with C's in it, clearly, that are very effective and very powerful. And that It matters because up until now, medicine has largely ignored it. So while these are just simply words on paper and or words on a screen for that matter, I think it does add fuel to the fire that this is an important topic. So our society here, Society of Academic Emergency Medicine, has also launched a commitment for clinician well-being and resilience, and also focusing on specifically academic emergency medicine. And I say that because I feel like wellness is a huge topic in medicine, and that initially we've got to solve it for smaller populations and then build it out to other populations. And there will always likely be disparities between specialties and genders and otherwise, but I feel like particularly in this society, in this meeting, and with these collaborations, we have the opportunity to mount that force and mount that enthusiasm to making real progress on a defined thing, a defined series of study subjects ourselves, and actually moving the needle to make it to make this meaningful. And this includes the identification of risk factors, interventions to prevent burnout and promote wellness, and more of emergency medicine is moving towards prevention and not just the treatment of disease. Interventions to frankly treat and mitigate burnout, and look at both individual and system level solutions. We've concentrated a lot on individuals specifically, and feeling as though providing extra nutrition and extra sleep, and some of the things we casually think about wellness, and it drives me nuts when somebody speaks about wellness and then there's like the yoga pose and whatever. It's so much more than that, but it's also so much more than nutrition and sleep and money. Just offering money doesn't make people happier. For a small amount of period of time it does, but that over the long term it doesn't. So we have a lot of, I think, system-wide solutions to consider. So the Wellness Committee and several of my esteemed colleagues put together a research priority for physician wellness for academic emergency medicine. And there are, I think, 3 themes overall that have emerged. One is to really figure out what the origin and natural history of burnout, resilience, and well-being are outside of what we grow up being. I think to some degree there are components of wellness and resilience and burnout even in childhood, but what is different once we become emergency medicine residents and clinicians and academicians? A emphasis on training and that population, I think, is critically important, because I think that's where we actually have chances for intervention that may be meaningful over the long-term career of emergency medicine. And hopefully those careers in emergency medicine are long-term, and be able to quantify the impact, attrition, and system solutions that actually make a meaningful difference. So shortly, before the end of the calendar year, SAEM will be embarking on an all-member survey for using the Stanford Wellness Survey to assess and just get a baseline of academic emergency medicine and where it sits. And the committee that's working on this is working on specific questions for academic emergency medicine, where we can tailor this to make this a specialty-specific thing. I'm not at all saying that wellness and burnout and resilience and moral injury are not important for all of medicine, but I think we have an opportunity, particularly for our very, very, very affected specialty, to come together and make meaningful findings and meaningful changes for our very specific population. So I'll close with, we can, we must, and we will conquer burnout in academic emergency medicine, just like we've conquered so many other things in our specialty. And so for the pivotal question, the science of physician wellness, is the truth out there? I will give you a resounding, sort of. I think components of it are out there, but I think emergency medicine is a unique specialty. We know it is. We have unique challenges and unique stressors that we have yet to truly find what the truth is for us out there. And I implore all of you to join me, to join the committee, to join SAEM in trying to figure this out for our specialty. I'm very grateful that you all guys came here today, and I hope you have a wonderful meeting. Thank you so much.